Good evening, everyone. Welcome to day 3 of the KZN Specialist Network Annual Conference. You must admit we've had 2 very interesting days so far with a wide range of topics, a wide variety of speakers. And tonight promises the same. We have both local and international speakers and several topics are being covered today. I must remind you once again, when you're logging on, to please log on with your MP number. This will ensure that you are registered for CPD purposes. Just in terms of our sponsors, you've seen the sponsors loop play at the start of this. I want to say a big thank you to all the sponsors for this conference. We've had a total of 16 sponsors. Just a quick mention that we have a competition running. If you look at the sponsors video loop, you would find catchwords in between the sponsors' videos. That makes up a sentence. Please answer that using the poll feature. You'll see that at the bottom. Click on the poll feature and submit your answers. We have some wonderful prizes, which will be done. The draw will be done late after the meeting finishes, and you'll be informed early next week of all the winners. We have an Apple iPad as a prize. We've got Fitbit watches, coffee machines, and some very good hampers. So please look at that and enter for the competition. In terms of interacting with the speakers and the panelists, can I please ask you to use the Q&A icon at the bottom? So please post any questions or comments you have. This will be visible to the speaker and the chairman of each of the sessions, and they could pose the questions on your behalf. However, if you feel that you really need to ask a live question, you can also do that. Just use the raise your hand feature and we'll see whether you can be accommodated as well. Lastly, just an appeal to all the presenters and all the panelists to please stick to the time frame. You know, we've got a full program, so we hope it all runs smoothly. So with that, I'll hand you back to the first speaker today, immediately after this video by Discovery, who are sponsoring the next speaker.
Good evening, all. For those of that you can't see me, it's not your fault and your vision is not poor. It's just my screen that's poor, but I think all of you do know me. So good evening and welcome to the last session of the KZN virtual conference. I think so far we've done exceptionally well with the topics. So we must congratulate Dr. Anil Bramdev and Tanya and their whole team for putting an excellent program together. And just looking at the program today, I think we look forward to interesting presentations. From my point of view, just before I introduce the speaker, I think the topic will draw your attention to the fact that it's largely about funding or how we get reimbursed going forward. As you all know, we probably in the throes of the medical aid that dictate how we get paid, what we can do, when we should motivate, when we should admit. Now, clearly we're coming to a point in time when we have to have change. Unfortunately, this change is coming a bit too late because I think the medical aids are really dominating the funding industry. You see from a hospital point of view, they have challenges, and we've always had challenges. So I think after this evening's talk, I'm sure there's going to be a lot of discussion of how doctors, or rather specialists, go forward in working in private practice and how we'll get reimbursed. I think the fee for service has been a noose around our neck. It's been comfortable for most of us. Unfortunately, it's come back to bite us. So we have to look at alternatives, and the alternative doesn't have to come from the funder or the medical aid. The alternative has to come from the doctor. So I'm sure after this talk by Dr. Schaefer, we have more insight and we'll be more motivated to look at opportunities like this. Having said that, it gives me great pleasure to introduce Dr. Jonathan Schaefer, who has been to our shows before. I've heard him speak. And surprisingly, he's an orthopedic surgeon that knows so much about medicine and business. You know, our orthopedic surgeons only know about hips and knees and not much else, but he's an exception. Dr. Schaefer has spent the last 20 years at the Cleveland Clinic and has been at the forefront and development of many programs, including My Consult, Dr. Connect, and more recently, the Global Medical Assist Program, where physicians and patients can deal directly with the Cleveland Clinic. But I think his real expertise is, from our point of view this evening, comes in to say, how can we learn from what the experience has been at the Cleveland and address the question I asked about how should doctors get reimbursed going forward? Particularly, we know that the NHI threat has been put forward for a long time, but until that comes, we still have to get reimbursed. So with that, I'm going to ask Dr. Schaefer to talk to us about multi-speciality group practice and the first 100 years. Thank you, Jonathan, and welcome to South Africa.
Well, Andrew, thank you for the kind introduction. It's certainly my sincere pleasure to return to South Africa, albeit virtually, and join my friends from the KZN Specialist Network for this virtual conference. For those of us at Cleveland Clinic, we all hope that you are safe and well during these challenging times. To those who have experienced hardship or loss, our thoughts and prayers are with you. To quote a common phrase we've all heard these days, help is on the way. While this is a holiday time, please take care of those surrounding you, your families, and yourselves. Well, we know that change is never easy, but it is necessary. And we as physicians really are charged with the task of leading that change. And so what I'd like to do is provide you with a view of a multi-specialty group practice, the first 100 years. We are about to celebrate our anniversary, our centennial. And what's going to happen afterwards? What's going to be the new normal? Well, to do that and to understand and come up with that answer, we have to first understand what was the normal. Was it ever normal? What does the future portend and when? And how do we respond to change? So how did we get, as the Cleveland Clinic, to this momentous occasion so that we're celebrating our centennial in 2021? You know, as I started to review everything for this talk today and to try and stimulate your thought processes, I was never a philosophy major, but I went back and I realized Kierkegaard actually said it best. He said, life can only be understood backwards, but it must be lived forwards. So if we're going to reflect on what we've done in the past, we have to look at the focus of the organization being solidly on the future. But to really understand the future, you have to have some reflections on the past, and that is the order of today. Now, in doing so, I have to say that there's a lot of similarities between KZN and Northeastern Ohio. As the population spread along the areas and the coast and the various other parts of the rural areas, the smaller city, I mean, Durban is just a tad bigger than Cleveland, but having the coastline, we have the North Coast, yours is the East Coast. The port, steel, minerals. Yes, our sports teams that have been out there trying to bring us championships occasionally, but always having their challenges. And then what are we doing in the new economies as we go from that steel and mineral environment to more of the technology? So what really makes a difference is the people, it's the patients, it's the caregivers, meaning the physician staff, down to the person in environmental services or the technicians, but there's many, many, many more. It's the shared goals. And for us at the clinic, that's called patients first. It's the systems and buildings that support that care. You have to have the right equipment, you have to have the right environment. And it's the collaboration that can make anything happen. And for us at the clinic, that's what we've done during the pandemic. Now that story is still being written, and perhaps at our next meeting, we can go through a lot of the details of what's happened during the pandemic. But we've gone from constructing a 1,000-bed hospital to changing many of our processes, to responding to how we take care of patients, but also our own caregivers, and doing that through virtual means. But more has been left out that's been included in this talk, and I'm indebted to many for their contributions to both the talk and to our organization. So let's start back before the founding of the Cleveland Clinic. We had 4 doctors that shared a vision. There were 3 surgeons and 1 internist. I mean, for many of you, you'd say the internist kept the surgeons straight, but we can get to that discussion at another time. It was set up as a not-for-profit physician-led group practice across disciplines. From the beginning, our physicians have been salaried, not based on volumes either. It's a patient-centered mission. And at the time of our founding, Cleveland, Ohio was America's 5th largest city. It was a real industrial hub because it was the crossroads of the railroads, the roads, and then the waterways as well. And our humble beginnings really have shown how we started. And I want to share some of those with you because we often reflect back on those and say, what would our 4 founders do when they set up the Cleveland Clinic? The challenges and the adversities that made them stronger and that have made us stronger. So George Kreil graduated from medical school, to put this in perspective, in 1988, and immediately joined Dr. Bunce as an assistant to the dean and professor at the Worcester University Department of Medicine. Worcester's just south of Cleveland. Their practice thrived, but then Weed tragically died and left Bunce and Kreil without a base of operations. We've saved a lot of our history, and here you see them, their practice location on Church Street. But we even in our documents have the first bill of lading when they sold Dr. Weed's practice goods to Doctors Bunce and Kreil. And our history is important. Every so often we have to go back and look at what we've done to better understand how we address things, what failures we had, but also what successes we had. So back in World War I, our docs ended up going to Europe before we were even drawn into the war to staff a field hospital. And if you've ever seen MASH, about mobile army surgical hospitals, they were among the first to provide care on the line where they were having battles. And so as we look at this, Doctors Bunce and Kreil would walk around and talk about how they would want to practice. And they realized in World War I, they practiced as a team, as a cohesive unit. And these nocturnal chats eventually led to shaping the Cleveland Clinic. So when they came back to town, they set up a Cleveland Clinic practice, originally in the Osborne building, one of the buildings downtown that still stands, to provide better care for the sick investigation into their problems, and education for those who serve. In 1921, our original building opened, and while it's been transformed many times, it still stands today. Originally, it was designed as a fireproof building, one of the first of its kind, which was very fortuitous. Because as we looked at the inside of the building, we had imaging labs and pharmacy on the first floor. It was really set up to be efficient. The clinical offices and the main waiting room were on the second floor that's depicted here. The clinical offices also on the third floor, and the fourth floor held the art and photography department, important even back then, the editorial offices, because there was a lot of publishing, the library, and a boardroom, as well as some of the offices of the administrators. So this became very important. Now, our charter was in fact provided in 1921, and it was really unique because there was personal underwriting by the founders for a not-for-profit corporation. There were fixed salaries not dependent on clinical activity. That still stands today. It was dedicated to community service, medical education, and resource, and there originally were 13 members in a group practice. Now, back then, the corporate practice of medicine, which this is what was considered in many states, was not allowed. And so they had to, in the state of Ohio, go through this. We didn't have that law in the state of Ohio, and that's why our charter was granted. And that has provided a solid foundation through the years, because most group practices had to have a different type of structure in order to be legal and not have the corporate practice of medicine. That's still the case in many states today, which frankly, many of us think will impede progress in developing care in those states. Our original hospital buildings were really quite simple. Here at the Oxley Homes, they put two homes together and provided the hospital care there. Well, unfortunately, in 1921, we had a disaster in that building. 72,000 films, which were nitrocellulose at the time, they ignited from a steam leak, overheated. Toxic gases hit the building. We lost 123 people, including our internist, Dr. John Phillips. But the resilience of the clinic being such is that we were able to reopen for clinical services in another building. Just 5 days later, we did an after-action review, involving the federal government. That resulted in the global adoption of revised safety codes for how films were stored and using non-explosive safety film, a major change. Well, if you know your dates, shortly thereafter, we had the US stock market crash, October of 1929, but we actually had built the S building. We're using letters for all of our buildings as well as names now, but the S building opened, but the crash hit, and we still had significant growth. We were able to grow even during this time thanks to our founders and people taking salary cuts because circulating money really had ceased to exist. But as Dr. Kreil said, its absence did not impede the incidence of disease. So here in an old photograph, this was campus back then with the original building down in the bottom right. And we were able to keep building and adding facilities so that we could provide healthcare. So in 1941, at the beginning of the war, we had been growing steadily since the Depression, and the number of employees went up to almost 750. We repaid the last of our debts for the buildings, and the founders relinquished the last of their administrative duties. Or as Dr. Kreil said, the child has learned to walk, but the road still leads uphill. Take us into the 50s. After the war, a lot of expansion, a lot of growth in America in general, and we started to change how we did things. We made changes in our administrative and professional staffing and how we managed it. The Board of Governors came into creation. That was elected medical staff, and they were charged with running the organization. They also reviewed staff members and rated performance. So that was the precursor of what has become our annual professional review. Along the way into the 50s and 60s, we also saw significant growth in the treatment of coronary artery disease and the surgery. So a little known fact is that in 1903, Dr. Kreil actually reported the first successful external chest compressions for resuscitation, successful resuscitation. And then Dr. Mason Sones actually was doing a aortogram, essentially is what we'd call it today, when he had the catheter tip a little bit closer at the root, got into the coronary arteries. The patient actually went into asystole. He told them to cough, and the coughing actually pushed the dye through. Well, he got a great view of the coronary arteries through angiography. That discovery has changed, as Dr. Fred Luke said, all the cardiology advances in the last few centuries pale in comparison with this achievement. And then Dr. Renee Favallaro from Buenos Aires, who practiced at the clinic for many years, actually bypassed an obstructed coronary artery with saphenous vein graft, thus beginning a significant growth phase at the Cleveland Clinic and having many people travel from all over the world to the clinic for cardiology care, for cardiac surgery. Well, that has continued through the days, but administratively, what's happened too is we made the annual professional review a very formal part of the process in 1975. And here we can see from the picture, growth was just starting on the bottom, the bottom left of the picture. I actually remember the clinic campus back then, what it looked like, and then new buildings starting to be put up because the growth continued at a rapid phase. We actually put up our first hotel because of the patients coming from overseas and other states. We really formalized our physician management structure and debt financing as well. Well, the annual appointments became very important. So I've been at the clinic 20 years. I've had 21-year appointments. That's how we're all looked at every year. And a bit more about the APR now, because it is the secret sauce to our culture. It's administered by the Office of Professional Staff Affairs. They look at all your accomplishments for the years. What are your career goals and plans? Did you accomplish this year what you said you would accomplish at your previous APR? How are you contributing to the department, to the institution, as well as to the community? And so looking at departmental matters and leadership, how are your leaders doing? How is your department chair, your center director, or the board of governors doing in handling things? The recommendations from the APR go up to the board of trustees and the compensation committee, and your salary is set and you get reappointed. Our letters in orthopedics come out on October. So every institute at the clinic or every department has a set time of the year they do this. We're now up to 4,200 staff. So you can imagine it has to be a well-oiled machine in order to work and to continually go and happen and occur and successfully complete. It is now a well-established and accepted part of our professional life at the clinic. Nothing like monitoring performance to help people make what is considered the optimal decision. So in a schematic, I just thought I'd show this here. Is the BOG member or the board of governors that represents your institute reviews the staff. So the staff puts together their report, they submit it. They then review it with the department or center or institute chair. It then is reviewed with a BOG member, and then that goes back up through the feedback. The institute chairs and department chairs present to the board of governors, and then there is the staff review of the APR feedback. You do get written feedback in this. It's an online system, and it really works quite well. There are changes that are being made constantly in this. So this is really something that has it stood the test of time for near 50 years now. Also, our logo came into being. And for those of you who've flown over downtown Cleveland on your way in, the airplanes go right over downtown, you'll say, gee, that looks like Public Square. There are 4 gardens on 4 corners where 2 streets intersect and a circular area around the outside. It shows that we look at clinical care, hospital care, and we look at education and research. Now, originally, these were yellowish and gold color, as well as green. As we went to a regional structure, we made it green and blue to reflect the region and main campus. Then it also shows quality, innovation, teamwork, service, our fundamental values, and each of the colors is meant to reflect and represent something as well. We call this the bug. Originally, they said it looks like a squashed bug, but it has become the emblem and the symbol, and really the centerpiece for the Cleveland Clinic, much as the KZN Specialist Network logo has done for your organization. It's part of the heritage, it's part of the culture, and we rely upon this, and everything we do includes the bug. In 1990s, we started on an era of tremendous growth. Dr. Luke, Dr. Straffen, our chief of staff, Dr. Luke was our CEO, had to deal with managed care. technological development went crazy. And before technology really got going on the web, consumerism really started to accelerate. We swung back to a more centralized approach. We looked at having chair and administrator dyads. So for every institute and every department, there is a chair and there's an administrator. We also had the economic challenges. You know, back in the 90s, there were a lot of different things at the governmental level, looking at different payment modalities and methods. The payers were trying to figure out how to control costs even back then, yet expansion. And same thing we said back in the Depression, disease does not take a break. So we started 3 major projects. The Century Project for building development, we were already 1,200 beds. But for those of you who have not been to Cleveland in the winter, we're in a winter wonderland this week, having had a very large snowstorm earlier on Tuesday. Having a skyway system that connected all the buildings, a walking pathway became very important, and that was started. It now connects everything and, of course, goes in a loop. An access center, cancer center, eye institute. And then we started the inner ring concept and having family health centers so that somebody didn't have to come to downtown Cleveland. They could be treated within 10 to 15 minutes of wherever their house was located. Now, for those of you who've been to our area, we don't have traffic like New York City, but still, if you're ill or you want to have health care, why not make it easy and take it to your community center? For example, as soon as I finish the talk today, I will be seeing patients this afternoon at one of those family health centers in Beechwood, Ohio, and I'll see patients till about 6 p.m. tonight. Our economic improvement plan, we developed a network. We developed regional medical practice at these different family health centers. We also started and expanded pediatrics. And the first of our hospital acquisitions was Marymount Hospital in the southern part of Cleveland itself, within the city. We looked at level scheduling, and ironically, what are we doing again today? We're looking at level scheduling. In other words, are you seeing 20% of your patients on Monday or Tuesday, Wednesday, Thursday, and Friday? That way, since you have fixed cost on each of those days, are you appropriately covering and using those resources most effectively? Budgeting, clinical product line focus, and our affiliations with other organizations like Ohio State and Kaiser. Well, we also started Cleveland Clinic Florida. Now that's been quite the journey where it's taken probably 25 years for that to really get off and get running, but it was an investment that has paid off handsomely through the years. People do leave the cold of Cleveland and go to Florida during the winter, otherwise known as snowbirds. So when they want healthcare, they wanted Cleveland Clinic healthcare. And we started to look at how we develop a medical practice. You know, you have to look at infrastructure. Infrastructure becomes very important because you need the right tools to do the work, whether it's a building or an IT infrastructure, fiscal infrastructure, or even something like marketing. How do you have the administrative operations to support the practice? Once you've established those two, you can certainly focus on clinical operations. And then, of course, the minute we set some standard, we want to transform it to something that's even greater, because the pinnacle of this is to provide value. What is value in healthcare? How do you do this? Value in healthcare is simply defined as the benefit over the cost. Well, who is to say what the benefit is? Well, the patient. I'm an orthopedic surgeon, as I was accused of being before, and I may think the x-rays look great, but it pales in comparison to how the patient feels after the operation. If they're feeling great, I can always pat myself on my shoulder for a great looking x-ray, but I'll let the patient pat me on the shoulder if they're feeling much better after I replace their knee. So we have to really look and define value as my health, as a patient, the patient's family health. What's the benefit there? And of course, what we want to do is look at benefit being time to diagnosis, time to treatment, making the right diagnosis, the optimal treatment, and the optimal outcome. Benefits should go up, costs should go down. And what we did is we looked at outcomes transparency. The quality counts when referring patients. Well, we publish our outcomes books, and we have done this for many years, going on 25, 30 years now, starting in cardiology and cardiac surgery originally. We have now expanded to 18 Northeast Ohio family health centers and 9 regional hospitals. We've had to close a couple of hospitals because the volumes have been low, but providing then a family health center in that area with a freestanding emergency room has frankly been more effective. How do we consolidate obstetrical services so that we can have optimal care yet make it convenient? And when we look at the ortho market in Northeastern Ohio, this is a great example where we started on main campus. By '05, we were in regional hospitals and family health centers. We then started to have standalone locations. We had other family health centers start to come up in 2017. And by 2020, this is what the map looked like, with orthopedics at all of our major hospitals, 7 joint centers around Northeast Ohio and Florida, and then seeing patients in the various communities. But expansion requires a model with connectivity. So we've gone through and having results reporting. We've had an electronic medical record, and this is the original image of what it looked like in the different parts that the EMR supported. This has been a cornerstone of us being able to expand, because if somebody has an X-ray in one location, I need to be able to see it and have the report available as well, no matter where I'm at. It also makes it easier for the patients. We rolled this out in '02, and we're now in our 18th year of implementation. Well, we then built a 1.1 million square foot Heart and Vascular Institute just after the turn of the century. We dealt with Y2K, and you can see the original building on the bottom right. This has everything to do with heart and vascular and thoracic surgery in one building. The operating rooms, the technical rooms, the consulting rooms, the ICUs. It's a rather unique structure. We built a new cancer center, and we changed the way we do things from a departmental structure to be really product line focused for the patients. And we have institute structure now. So orthopedics is Orthopedic and Rheumatologic Institute. Dermatology and plastic surgery are grouped together. All the digestive disease and surgery, so GI surgery, colorectal surgery, are all together. And this has been a huge change in how we organize things. And between 2010 and 2020, we've gone through a number of cultural shifts where we've looked at patients first, empathy, and these are all parts of much longer stories that time doesn't permit us to go through today. But innovation, continuous improvement, diversity and inclusion, and then global cultural transformation. How do we have the same process, whether you're in Cleveland, Las Vegas, Canada, wherever we're at? And we looked at wellness, because if we're not taking care of our own employees, that makes it more challenging. So we've gone to smoke-free campuses, not hiring smokers. How do we help with our employee health programs on food, physical activity, and stress? We have bent the curve on costs while increasing benefits. We try and reverse diseases through Lifestyle 180 and then our preventative and executive health centers. We also found the need of how do we get, if we're going to localize resources at one hospital, we use our critical care transport program to bring people to the most appropriate place for them to receive care. And so we have both helicopters, fixed wing, and ground vehicles that transport people to the facility where the care is need to be delivered. We also have our e-hospital operations center, which is operational from 7 p.m. to 7 a.m., 7 days a week, where we can monitor patients in the ICU, helping out the on-site intensivist and their team so that we can see things before they have some ill effect. And our algorithms have proven that we can make that happen. We then built Cleveland Clinic Abu Dhabi with the Emirati government, and we staff it. It's now over 375 beds. They did very well during the pandemic to become the resource for the Emirates. And this is what it looks like today. And if any of you have had a chance to go there, it is quite an amazing facility. And if you look to the right there, you see the bug, the logo there in the parking lot in the gardens. And that is where the new cancer center is actually going up. It's currently under construction. So this has taken our model to another country entirely. We then look at what we're doing in London, replacing this building with now a 200-bed hospital in the heart of London, and that will open in 2022. Florida has also seen regional expansion just in 2019, going from 155 beds to over 1,000, and really covering the eastern seaboard of Florida from Indian River down south to Fort Lauderdale. We did have a facility in Naples, and that couldn't be sustained because the state would not give us a certificate of need for heart surgery. But just this past week, we have announced a strategic relationship with the local provider there, Lee Health, and that will be our re-entry into that marketplace. So it's been rather unique. We've become a global multi-specialty group practice, and we've learned a lot along the way, and hopefully you've picked up some of the important things that have helped us. But we have facilities both stateside and in Canada, so in North America, and then overseas in Abu Dhabi, London opening up, and many of you know Shanghai will open in the near future. But having representative offices, branded affiliations, and digital health relationships all over the world. And the Shanghai facility will open up closer to 2024 now, but we're having other places as well where we've been asked to look at how we can provide our system of care. And it really looks at cooperation, compassion, and innovation. You have to have the right mission statement, the right vision statement, the care priorities, the strategic goals, and the values that follow. And how do you get these across? We've done this through webinars, training programs, and all the employees have gone through various training programs because we use computer-based training and do it quite effectively. So we have been nonprofit from the beginning as a group practice with physician leadership. Salaried positions make a huge difference. We can make the right decision, and we feel the optimal decision because we take one of the biases that's there out of the picture. And one-year contracts really keeps everybody on their toes. It is a challenge. Not everybody gets renewed, but if you do the right thing and take good care of the patients, then you get renewed. We want to be the best place for healthcare anywhere and the best place to work in healthcare. And hopefully this has given you a bit of a view of how we've done it and how we're going to do it in the future. And we've addressed the pandemic. It's not been easy. We're not done yet. We're in the middle of a huge surge in Ohio and Northern Ohio, but our teams have gotten through it. We've been led by our CEO and the entire administrative team to do it. Again, all physicians. And we always say every life deserves world-class care. This is what we want to do going into the future post-pandemic. And I just thought I'd share one more slide because that's what Cleveland looks like when it snows. That's main campus, and we are buried in snow. So hopefully there's a couple of questions and be happy to address them. Thank you.
Thanks, Jonathan, for a fascinating overview of what is really a very interesting medical facility, but more than that, the professional care. That's the message I got largely, that it was driven by doctors, managed by doctors, and you can still earn a good income without necessarily looking at it as profit. So conceptually, that is different to what we do in this country. It's something we need to address. Just from a very small, as you said, Cleveland is very much like Durban. We as doctors have started in the hospital business many years ago, and they still exist, these companies. I think maybe there's an opportunity for us to revisit that and adapt that model to the kind of model that you put together. And clearly it is, everybody's a winner in the process. So thank you for that. I'm going to ask Tessie Reddy, who is one of our directors on the KZN Specialist Network, and he brought this concept of the Cleveland Clinic model many years ago to us. And I just want his short comment before we take any questions or comments from the audience.
I think the fact that I brought the Cleveland model is probably just from listening to you. We had the privilege of being a provincial team, and in KwaZulu-Natal, Specialist Network became well known throughout the country. And the issue was, could we then formalize this into a business? And putting together multi-specialists, and the issue then remained, what risk could we carry if we were then to engage people as large as Discovery Health, and there were other funders. In this area, we ultimately got together with key people in KPMG who could do the accounting background and set up a team. The difficulty was in getting traction with the specialists in a way that you did, starting with 4 or 5 doctors and then developing it. We already had a developed health system, and impending was a future national health insurance. So we didn't make progress in those areas, but what we did make progress with was payment arrangements with funders. And as Andrew has said, this may have come back to pose some difficulties for doctors. And it now raises the issue, could we change the way we practice medicine in the way the Cleveland Clinic does? Not necessarily just for profit, but that doctors are properly reimbursed and work the correct hours. And from the audience, we'll open some questions.
Thanks, Tessie. Jonathan, if I could just make the point that you made one or two things coming out from your talk. I think the issue of value is a key word that you brought out. And the second one was benefit. How is it measured? Now, unfortunately, in our present system in South Africa, the benefit issue and the value is not being assessed. It's being measured by funders, and they really look at the cost rather than anything else. And as you showed, what benefit, what does the equation of value equal to? Benefit over the cost. So it's something that we'll have to address. I'm not going to go on any further. Are there any questions from the audience or any comments?
You know, I might just make one comment if I could. You know, value, yes, funders are focused on how much it costs, because if they're not being able to balance what comes in and what goes out, it's a bit of a challenge. It's not sustainable. So I think we have to work as clinicians with the funders to help understand what we see as value, but what the patient sees as value. Why am I doing a knee replacement? You know, is somebody going to be able to use it effectively? Are they ambulatory? And then what are the clinical results? This has to be done mutually. And it's not just the insurance companies and payers that have to do this, but it's also the legislation. You know, how do we educate them on what clinical benefit is? When we went into Florida, there were some challenges with the way the state laws were written in Florida. We have to work with the legislator to make whatever changes are needed or find a way of coming to common ground. It's not easy. It is a journey. It's taken us 100 years. So, and who knows what challenge is going to come tomorrow. I don't think any of us would have foreseen a pandemic in 2020. So it's having the resilience of an organization. And, you know, many of us at the clinic are simply stewards of that for some short period of time before somebody else fills our shoes. So succession planning becomes important.
Thank you, Jonathan. Just before we close, I'd just like to, I should be remiss of me not to mention our chairman, Dr. Eminadu, who is unwell. But in the more recent past, he's been pushing for the Cleveland model. So I hope he's listening, or at least this message gets to him that we are addressing it. And it leaves me just to thank you for an excellent presentation. You've given us lots of things to think about. And I think particularly the younger specialists need to get involved and address these issues going forward. So thank you again, and over to you, Anil.
Thank you, Andrew, and thank you, Dr. Schaefer, for an amazing talk.
Thank you very much. Certainly it's been a pleasure, and Godspeed to everybody, and stay well.
Thank you, Jonathan. We will interact with you in the future, hopefully.
Thank you so much.
Thank you, Dr. Schaefer, for a very good talk. It gives me great pleasure
Yes.
Hello.
Hello.
Gitesh, go ahead. You're live, Gitesh. Go ahead.
Hi, I'm Gitesh Ramprasad. It gives me great pleasure and honor to introduce the next speaker, who is very well known to all of us. Professor McCoy Mason's short CV is 3 pages. And if I have to read out the whole 3 pages, we'll take his time for the meeting. He is a prof of law based at the Center for Social Legal Studies at the KZN and is an advocate of the High Court of South Africa. He founded the South African Street Law Program and is the chairperson of the Durban Medical Legal Forum. Prof is a National Research Foundation member rated A class and is an active teacher up till now. He specializes in medical law, access to justice, and street law and human rights. Prof has visited more than 125 countries and has facilitated numerous training workshops on street law, human rights, and democracy. Professor McLeod Mason has published more than 200 articles in law and medical journals, contributed to more than 70 chapters to books, and has co-authored 24 books and manuals. It gives me great pleasure to invite Professor McLeod Mason to deliver his talk entitled Medical Legal Issues and Ethics Post-COVID-19. Over to you, Prof.
Thank you very much for that introduction. I'm glad you didn't eat up any more time. Next slide, please, Renard. Okay, so as we all know, pandemics cause particular problems. I've done a fairly detailed slide presentation because I'm hoping it'll be handed out to delegates afterwards. But this is going to affect not only the ethical principles, but the civil and criminal law in healthcare as well. And very often there's a reaction to it in the legal framework, which can take the form, as in our country, a national state of disaster or a state of emergency. And even though we have the pandemic now, and we think we're going to get vaccines quite soon, that pandemic is going to be around for a while, and we're likely to get other pandemics arising as well. So I'm going to locate what I talk about mainly in the lessons we're learning during the COVID-19 pandemic, but also things that I think are relevant to something in the future. And because of these very strict measures that have to be taken under national disaster management or emergency regulations, these obviously have quite serious consequences for ethical and legal service matters. I'm going to actually base my talk on a number of articles I've written in the SAMJ, and I'll list them right at the end for you as well. But as you guys are getting CPD points, I'm going to give you a scenario at the end for you to discuss also. Next slide. Okay, so we know that our restrictions have been some of the most restrictive in the world, and they've restricted a lot of things which our constitution gives us: movement of persons, limitations of public gatherings, mandatory testing and quarantining for people who test positive or have been in contact with COVID-19, compulsory reporting of infections, restrictions on cigarettes and alcohol, as well as risk-adjusted lifting of restrictions. We've seen what's happened here now with the Eastern Cape and the Garden Route in the Western Cape, how things are having to be reimposed again. If one looks at the Disaster Management Act, a disaster is called a progressive or sudden, widespread or localized natural or human-caused occurrence, which threatens to cause death, injury, or disease. And that's squarely what's happening here. A state of disaster has to be renewed every month, and you've seen it's just been renewed now right through to January. It's unlike a state of emergency, which has to be introduced by a special act of parliament and can only be introduced if there's a situation of unrest affecting peace and order in the country as well. Even though we have a state of emergency, there are certain rights in our Bill of Rights which cannot be, which the lawyers call derogable. They cannot be taken away, and that is equality, human dignity, life, freedom, security of the person, freedom from slavery, servitude, and the rights of children and arrested and detained persons. We'll see just later, there's some areas which are not derogable, which are not derogable, rather, which affect the things I'm going to talk about now. Next slide, please. Okay, so some of the common ethical and legal situations which arise are, we need to look at the relationship between law and ethics during pandemics, the limitations on freedom of movement, limitations on informed consent, one of the foundations of medical practice, limitations on confidentiality, another foundation of medical practice, limitations on freedom of association, problems of providing personal protective equipment. People, and this happened in the Western Cape, where even though healthcare providers were being provided with the correct PPE, they still refused to treat patients. So we'll talk about that. There are problems of delayed test results, which you can have. Sometimes when you need to undertake an autopsy to see if someone's died from a pandemic or from COVID, you get relatives who object to that. So what do we do in that situation? And then lastly, whether COVID-19 patients who require ICU, if they can be regarded as requiring emergency medical treatment, which is guaranteed under the Constitution. Next slide, please. Okay, so the bioethical principles, and I always tell practitioners this, the principles of autonomy, beneficence, non-maleficence, and justice or fairness, if you just follow those, they will completely cover you as far as the law is concerned and as far as your ethical rules are. Whatever the details in the rules are, whatever you find in the Bill of Rights, in the Constitution, all of them can fall into those 4 categories. And as long as you use those as your guidelines, generally you'll be acting in accordance with the rules of your profession. Those of you registered with the HPCSA, which, as you know, is there to protect the public and guide the profession. Practitioners will also be acting in line with the Constitution, the statute laws, such as the National Health Act and the Health Professions Act, as well as the common law. But in terms of our Constitution, certain of these rights can be limited, provided it's reasonable and justifiable to do so, and that the less restrictive methods are used. So they have to be proportionate to the harm that is trying to be prevented, and they have to be the least restrictive way of preventing or halting a pandemic. Next slide, please. Okay, limitations on freedom of movement. Sometimes, as we've seen in the regulations for COVID, you've got to limit freedom of movement to stop people spreading it. And it also requires social distancing apart from wearing of masks as well, and sanitizing. And so what has happened then is you get things like people having to go into isolation, people having to be quarantined, closing of schools, cancellation of public events, closing of public venues, curfews, and limitation on travel between provinces and other places. All of those are limitations on freedom of movement. And then usually they should only be imposed, of course, where voluntary actions are unlikely to be effective in order to spread or halt the spread of the pandemic. And we've seen that there's a lot of concern now about what is going to happen over the festive season. And the president last night pleaded with us to try and make sure that we do these things, even though they're supposed to be compulsory. We know that a lot of people are ignoring them. So that you can impose these restrictions on individual freedoms, provided, again, you're doing it to prevent other people from not threatening the health and well-being of the general public, because the Constitution says we're all entitled to an environment which is not harmful to our health and well-being. And that is echoed again in the National Health Act. And we'll see later, it crops up also in different forms in the common law. Next slide, please. Okay, the other one, and this is a big one because it's one of the foundations of your practice, but you might have to impose strict measures to prevent the halt or spread of a pandemic, some of which are going to violate the patient's right to bodily and psychological integrity, requiring them to undergo screening, testing, treatment of the disease without consent if necessary. And that is provided for in our COVID-19 regulations. They provide that anyone who's been clinically or by a laboratory confirmed as having COVID-19, who is suspected of having contracted it, and this is important, or has been in contact with a person who's a carrier of COVID-19, may not refuse one medical examination, including bodily samples, admission to a health establishment or quarantine or isolation site, or submission to mandatory prophylaxis, treatment, isolation or quarantine or isolation to prevent the transmission. And if you're not allowed to refuse to do that, and there's a provision there in the regulation which says any person who intentionally exposes another person to COVID-19 may be prosecuted for an offense. And they go on to say, including assault, attempted murder, or murder. Of course, it has to be intentional, not simply negligence. Next slide. Next slide, please. All right, again, the other foundational principle of medical practice, confidentiality. Again, it's sometimes necessary to deal with that constitutional right of privacy and confidentiality, and to limit it in order to prevent or halt the spread of the pandemic. The common law says that if you are in a position where you are going to endanger third parties, then if a person knows about it, they have to warn the third party. So even in the common law, that provision did exist. But the HPCSA, as you know, not only protects the public, but it guides the profession. And it says that registered practitioners should report any unprofessional, illegal, or unethical conduct on the part of another practitioner to the council. So if they do something which they are not actually protecting patients by reporting a colleague maybe who's putting them at risk, they can breach the confidentiality rule, because it's a privileged occasion in order to inform the Health Professions Council. But patients themselves need to know, although health practitioners are ethically bound to continue to respect their confidentiality, they also have to comply with the demands of the law. And so the COVID-19 regulations do try and deal with confidentiality. And they say that, patients' copies of their documents are sent to the Director General for inclusion in the COVID-19 database, but that information has to be kept confidential. So it's necessary to tell patients that as well. And then that information is sent to the person who's appointed as a designated judge of the High Court, going to ensure that it's only being used for the purpose of the regulations, and other people aren't having unauthorized access to it. And you cannot disclose this to anybody else unless it's necessary to spread to prevent the spread of the epidemic in terms of the regulations. Next slide, please. Limitations on freedom of association, that is people gathering together, sometimes again in order to prevent particularly the so-called super spread situations, as we've heard about, often happens at big funerals, maybe as happened in the Free State, for instance, where people get together, they don't take the COVID-19 bundle of precautions, and then the whole event becomes a super spreader. And it's remember again that people who have been clinically confirmed to have contracted it, suspected of getting, or has been in contact with a person who's a carrier of COVID-19 may not refuse to admission to an established health establishment or quarantine or isolation site, or refuse mandatory prophylaxis, treatment, isolation, or quarantine to prevent transmission. If they refuse to consent, they can be forcibly quarantined for up to 48 hours until a court order has been obtained for their detention. And so we've seen during our COVID-19 pandemic, for instance, forms of association have included things like holding night vigils at funerals, conducting transitional initiation schools, visiting listed places usually open to the public that are closed, visiting beaches or public parks, visiting health establishments except for medical treatment. Some of those now have been lifted. You heard what the president said last night about traditional initiation schools. We've been able to go to the beaches and parks for quite a while as well, but we have to take those precautions. And then the question of personal protective equipment, particularly where there's a shortage of resources. Again, not only do you have that constitutional right to your bodily security, but the Occupational Health and Safety Act says that Workers have the right to an environment which is not harmful to their health and safety. If there's a shortage, then obviously the frontline health workers should be given preference, followed by maybe the elderlies and the others who are greatest at risk. And as you will, that's happening now with the procurement of COVID-19. Chair, just keep an eye on me and tell me how the time is going. During the pandemic, the health and safety of healthcare workers is obviously paramount, because if they're going to care for patients properly, they should be in a position where they're not going to be spreaders themselves. If they fail to provide PPE and the workers are going to be exposed to the virus, then they ethically and legally can refuse to work. And the people who are responsible and are not providing them with those supplies might be criminally liable, not only under the Occupational Health and Safety Act, but under the regulations, because they would then be intentionally exposing people to COVID-19 infection. Next slide, please. Next one. Frontline, now this is the one I mentioned a bit earlier, where you get people who have been getting the proper PPE, but they say, I still don't want to treat COVID-19 patients. Now that clearly is a constitutional breach, where people actually require emergency medical treatment situations. But even then, it's also an ethical breach of the World Medical Association International Code of Medical Ethics. In the case of nurses, it's a breach of their international code. The breaches it's also a breach of the HPCSA, the Nursing Council, and relative labor legislation. So if there's no reasonable and justifiable cause for treating the patients, then they're breaching all these, and they can end up being not only reported for unprofessional conduct, but they might be prosecuted in terms of the law. Next slide, please. Right, another problem has been delayed tests. We hope this will change when we get rapid testing. The problem here is you might get a situation where a GP wants to refer someone to a specialist, but the specialist is not going to be able to treat the person properly unless they know the COVID-19, for example, or pandemic status of the patient. And it's not much good if the tests were taken 10 days or 2 weeks earlier, because at that stage, the patient may well have been negative, or the virus might be incubating or something. Where one can delay the treatment for a short period, say 24 hours or so, it might be possible to get a new test done with a quick turnaround. But if you cannot delay and you haven't got a test, at the moment you just have to do a sort of judgment call based on the clinical symptoms. And then we hope eventually this rapid test, I think it's a 5-minute test, will become available. Next slide, please. Okay, there's also the problem briefly mentioned before, where sometimes it's necessary to conduct an autopsy or to get some tissue from deceased persons who might have been exposed to the COVID-19 virus in order to determine whether they've died from that type of illness or not, because that's important, not only where the critical care facilities are trying to work out what they should be doing differently or whatever, so it helps them to improve their care of patients in ICU, but also the government needs to plan and how it's going to deal with this. And if it gets a distorted image of the number of people who are dying from COVID-19 and the number of COVID-19 cases, it doesn't help their planning. So I've suggested that in these situations, although the legislation says you're supposed to get the consent of the nearest relatives, that it is not necessary, where again, it's necessary for you to take precautions in the public interest to make sure that these people who have died have not had COVID, because not only is it necessary for planning and for the government, but also the members of the family. They also need to know whether they've now been exposed, their family or their friends, the healthcare practitioners who help them, undertakers, staff, anybody who's been in contact also needs to know about that as well. Next slide, please. I think it's the last one on this slide. Okay, the other one is, can extended ICU COVID-19 care be seen as emergency medical treatment? Constitution says nobody may be refused. We've had the famous Subramani case, which was in KZN, where the Constitutional Court held that renal failure patients whose condition is chronic and incurable, and the important word there is incurable, do not qualify emergency medical treatment because the harm cannot be diverted, the words used by the court. However, it might be that COVID-19 patients requiring extended ventilation, they maybe chronically ill for a while. It might take a few weeks or months to get over it, but it is not incurable always. And because of that, I think it could an argument could be made that they are entitled to emergency medical treatment if they need to be put on a ventilator to keep them going until they can be swapped. We appreciate that the survival rate is not very good on ventilators, but still there's a chance that they could be cured. Okay, and then of course, if it has to be withdrawn because their condition has become terminal or now futile, then you can withhold or withdraw and provide palliative care as required by the Health Profession Council guidelines. Okay, next slide. Next one. Right, conclusion then. So while upholding the principle of respect for individual freedom, the reality is that during pandemics, restrictions are necessary to protect the health and being of the public, which the Constitution says must be done. The most appropriate framework needs to be selected. It might be a disaster management situation or state of emergency. It's often difficult to balance the competing interests during a pandemic, but you've got to take into account both individuals and societal interests. And the best way of doing this is to look at your bioethical principles, the autonomy, beneficence, non-maleficence, justice, and fairness when you're trying to balance these interests. During pandemics, extreme measures may be taken, which result in certain human rights and freedoms. We've mentioned the movement, bodily integrity, privacy, and freedom being infringed. As long as it's reasonable and justifiable, it's the least restrictive method of preventing or halting the spread, that is acceptable. And one has to take special care to make sure that suitable personal protective equipment is available, especially for frontline health personnel, to prevent the halt and spread of the pandemic. That's all I want to say now, but I want to now make you guys earn your CPD points. Chair, we got 5 minutes or so for them to discuss something. Chair, how are we for time?
Yes, Prof.
Can we go for 5 minutes? Okay, thanks, Neil. All right, let's go next slide. Okay, this is a scenario. I've called it, what should the doctors in the partnership do? This is a real case, by the way. 5 specialists are partners in an obstetrics and gynecology practice. The overheads for the practice, particularly for medical malpractice, are very high. One of the partners contracts COVID-19. 3 of the partners go into self-isolation. Because of the very high overheads, another of the partners, Dr. Trump, refuses to self-isolate and to discontinue seeing patients in his surgery. He also continues to deliver babies by cesarean section at the local hospital. His other partners are concerned that Dr. Trump might be breaking the law, which will damage the reputation of the practice. The infected colleague and other 3 specialists wish to know, is Dr. Trump in breach of the COVID-19 regulations under the Disaster Management Act? In terms of the regulations or the HPCSA ethical rules, are they required to do anything about Dr. Trump as their colleague? Normally I'd get you guys to discuss this in groups, but there are too many of you here. So maybe if anybody got any ideas, they can stick their hand up, unless you guys want to do it on the chat as well. Chair, I'm not sure how you want to handle it. They can do it on a chat. It's quite a long question though. But I guess we could make it short and just, is he breaching the COVID-19 regulations? And do his colleagues have to report him to anybody? Can you see any hands, Chair? I can't see, I'm not a host, so I don't know, can't see any hands.
No, there are no hands, Prof.
No hands yet.
I
can't go around.
I think the delegates can use the Q&A section and answer there. And so we can see it coming up on the Q&A.
Okay, well, they see it. I can see, what if you've got comorbidity? I can't see anything else at the moment on Q&A.
No, there's nothing related to the question, Prof.
Sorry? Okay.
There's no Q&As relating to your question.
Well, somebody going to put it on? You mean I just speak or what?
Yes.
Hi, Prof. There's Dr. Sandrini Murli has a hand up if you want to address her.
Yes, good. Let's hear it. Yes, thanks, Dr. Murli. Yeah. What does she say? Dr. Murli?
Sandrini Pillay.
That's, Dr. Pillay, yes, okay. Let's hear it. What's your answer to? Yeah.
Hi,
Little louder, please.
I think every healthcare professional has a responsibility in terms of containing this pandemic. And I think that this Dr. Trump would definitely be in breach if he continued to work, knowing that he has had a positive contact. So I think we have a responsibility to actually warn against this kind of behavior. I think it's very important as healthcare professionals, we should be leading the way in responsible behavior. So
I think
that's what I feel. Thanks.
Good, no, and I think also just remember that he's committing a criminal offense in terms of the COVID-19. So someone needs to counsel him and say, look, if you don't do it, you are going to be charged criminally. And that means you're going to then end up with an unprofessional thing as well. A criminal offense if you intentionally expose other people to COVID-19. Yeah, is there somebody else? What about the second question, anyone? The second part. You think they have to do anything? Okay, they can counsel him. If he ignores the advice, what can they do? Anyone?
Well, Prof, there's a comment they're saying it depends whether Dr. Trump is a high or low risk contact.
Okay. All right. Does it matter whether you high? Presumably, patients in his room, you mean they might have all taken precautions and avoided it? Is that the suggestion?
I think most of the questions coming through saying that he says
Okay.
that he's in
Well, what
breach
if
and
people-
needs to be reported. Yeah.
Okay. And who are they going to report him to? Are they telling us who they want to report him to?
I'm not sure. Probably HPCSA.
Yeah, well, that's, remember that little rule I showed you earlier on. It says there that you have to, it talks about impairment or people, who are a danger to the patient. So here's a situation where he is a danger to or potential danger anyway to the patient. Practice, if patients know, that practice there, doctors is COVID-19 and they're not doing anything. Okay, Chair, I think that's about it. Yeah, I've just listed all these. It looks a bit egocentric, but I've written on all of these, and if people want to find them, there are all the references for you. Chair, anything else?
Prof, thank you very much.
Okay, pleasure.
Thank you very much for a very interesting talk and clarifying many issues that are very important in terms of the ethics in COVID-19. It was a very succinct talk. And I'm sure there are going to be a lot of questions which we'll forward to you in the future. But thank you very much once again for
pleasure. Okay, thanks for inviting me. Okay.
Good evening, everyone. Thank you, Prof, for the insightful talk. It's an honor and a privilege to introduce Dr. Conrad Mashelwane, our next speaker. Dr. Mashelwane graduated from the University of KwaZulu-Natal in 2002, and then subsequently completed his specialization in obstetrics and gynecology in 2002. He also has an interest in medical legal practice, as well as having a degree in human and social sciences. Currently, Dr. Mashelwane holds directorships in both the South African Private Practitioner Forum, as well as the KZN Specialist Network. His talk today is entitled Rule 41A and Medical Malpractice. Conrad, I'll hand over to you.
Thank you, Session. Let me just orientate myself here. Okay, I think I'm okay. You can see my screen? Thank you. All right, today I'm going to be talking about on Rule 41 and medical malpractice. Rule 41 is basically an amendment to the Uniform Rules of Court. It basically says that if you receive summons from a plaintiff or the patient that's laying a case against you, it must be accompanied by Form 27. And then when you then file a notice of intention to defend, that must also be accompanied by Form 27. Form 27, I wrote Form 26 it's Form 27. What Form 27 says that please take notice that plaintiff, applicant, defendant, or respondent agrees to or opposes referral of this matter to mediation. And then it says plaintiff or defendant or a respondent or applicant does it for the following reasons. Basically, it now gives us an opportunity to go into mediation once summons have been sent. And the decision to mediate must be done before any replying affidavit or preparation of pleadings. And this can be done anytime before a judgment if parties agree. Sometimes the judge may actually order both parties to go into mediation. And the time limit for delivery of pleadings and notice and filing of affidavit is suspended. Basically, once you decide that you are going to mediation, the legal processes stop, and now the Civil Procedure Act gives you 30 days to go into mediation. Now, you can request a joint opinion. As a member of SASOG, we basically set up an independent body called the Expert Opinion Panel that allows you an opportunity to get an unbiased opinion, which can basically be a joint opinion for you and your plaintiff and the plaintiff before you go into mediation. And this is the most important innovation in the Civil Procedure Act because it allows us, it assists us in medical malpractice. And I think the profession now must be aggressive and take this with both hands. And I want to tell you why. Because mediation has got a 90% success rate. It's cost effective. It maintains the relationships after. And it can be done in a day or two. And then for me, what mediation does, it gives me the opportunity to go and actually meet the patient and to say, I'm sorry. When you say I'm sorry, it doesn't mean that you are guilty. It means that you are sympathetic because the patient is angry with you. And it's only reasonable, whether you think you are guilty or not, to say sorry because the patient feels they are angry, they've suffered. And I think it's reasonable to say, I'm sorry. And if you believe that you are innocent, you can tell the patient, had I foreseen this, I would have done things differently. And you can ask the patient, how did I fall short of your expectations? And you can explain to the patient what you think happened in a humble manner without passing judgment. It gives you the opportunity to conciliate, mediate, and reach some compromises. Why attempt mediation? There's something that we never discuss. We always hear about it. It's the common law. What is the common law? For the last 3 years, I've done extensive research on the common law because I cannot find a book on the common law. What is the common law? Now, this is the common law court process. Now, it promotes party autonomy. This is my approach in my practice when a patient comes to me complaining that her body is troubling her. I look for the complaint and I decide on the merit of the complaint. I don't just basically do a CT scan on every patient that has a headache. I must decide objectively if this patient, there's a merit to this. And maybe the patient's got psychosomatic illnesses. I need to take that into consideration and not over-service. Our health resources are strained. I must do an examination. I must investigate. I must make a diagnosis and I must treat. And our courts is that it's subjective. The patient basically lays a complaint and the patient is the one that decides on the merit of the complaint and can go to court because they've decided there's a case. Now the person examines the facts, it decides, the attorneys and the experts. The person investigates the law, it's the advocate. The person who passes judgment is the judge. The remedy, you got damages experts. You got so many people involved. When everything is done, the patient basically has nothing left in their pocket. I did a case in the Eastern Cape, which I lost. I was very angry because I believe that the state managed the patient well. And my advocate told me, you know what, this patient is going to get she's going to get 18 million, but she'll only be left with about 2 million rands in the pocket because all the money gets eaten up by the experts. Sometimes you have 25 people involved in one case. What the patient is left with absolutely nothing after 5 to 6 years of trying to get something for themselves. Now, if I basically looked into what is Roman law. Now, if you go to classic Roman law, when Rome was a republic, this is how a case was conducted in the courts. And basically Roman law has become the sort of ideal legal system. Everybody wants to copy the legal system of Rome when it was a republic. Rome was a monarch. The legal system was basically handled by priests, and the priests were overthrown. And the republic, the people took over the legal system. And this is a model legal system that we are trying to model. The legal system in Rome was handled by a person called a praetor, or a magistrate. Now, a magistrate doesn't have the same meaning as we have today. A magistrate was somebody similar to a director general and a minister. These are the people who handled legal cases. And if you have a case, you go to a magistrate, and an executive, he decides, looks at your complaint and decides on the merits of the complaints. He examines the facts, he investigates the law, he can pass judgment, or he can appoint a judge, and it's a judge was a lay person, and he decides on the remedy. Now it's one person that is involved in the entire case. He decides on the merit of the complaints, he examines the facts, he investigates the law, and then he passes judgment, appoints a judge, and he decides on the remedy. Similar to what we do as medical practitioners. Objectively, he does it objectively. If you look at the mainland Europe, they've got what's called a civil law system. They basically follow the Roman system. The European system is a Roman-based system where the courts use an objective approach where the judge handles the entire case. He decides on the merits of the complaints, the judge examines the facts himself, the judge investigates the law, the judge passes judgment, and the judge decides on the remedy. One person. And you see that litigation is a problem in common law countries because it is extremely inefficient, it's speculative, it leaves everything to the two teams. Nobody actually represents the law. Now, if you look at the common procedure system, I've done some medical legal cases. First of all, the two parties must agree on the law. They must investigate the law independently. It takes a long time. It can take 3 to 5 years. People must go to the library to investigate the law. And the law is investigated based on what? On allegations. The evidence is presented in court. For the first time now, there's arguments around evidence, only in court. It's never, the advocates are discouraged from discussing evidence before they reach the court. And after judgment is passed. Now, this is a person that I came across. His name is Jeremy Bentham. He's probably the architect of what we call legislation today. He said the laws must be written down so everybody can see the law. He's the person who came up with the principles of utilitarianism. What does utilitarianism mean? He said law must be outcome-based. Now we are going to value-based care, outcome-based care. He came up with a concept 200 years ago, and he said you must measure the outcomes of the law, the pleasure it causes to you and the pain it causes to you. He says publicity is the very soul of justice. It is the keenest spur to exertion and the shortest of all guards against improbability. You know, when we all know what the law is, we then basically are forced to exercise the law, and it prevents people from being dishonest. This is what Jeremy Bentham said. His followers call him positivism because he said only the state can make the law, not judges. Now, the name positivism actually comes from this person, Auguste Comte. He is a French person. He was the leading thinker in the 19th century after the French Revolution. He said that the law must be empirical. He said to develop the law, you must understand the progress of science, that science progresses in this manner. Science progresses from astronomy towards physics, chemistry, biology, sociology. He said sociology is the last frontier of science. Today we are going into AI. Professor on Wednesday was talking about AI. What is AI? It is the socializations of machines. We are basically making machines part of our society. And it brings me to my next point. HLA Hart, This is the leading thinker of common law in the 20th century. He was a professor of jurisprudence in Oxford. He was the most biggest critic of common law. Any arguments about common law starts with H.L. Hart and ends with H.L. Hart. It's a response to him. He was an advocate from 1932 to the 1940s, and he was a professor of jurisprudence in Oxford from 1952 to 1973. He wrote a book called The Concept of Law. It's one of the most important books on common law of the 20th century. You know, ladies and gentlemen, we like esoteric knowledge. We forget the basics. Now, I think probably the most important, the most famous scientist to date is Albert Einstein. And we like these esoteric things that make us feel special and intelligent. What is E is equal to MC squared? It's an equation that actually means nothing. You know, the problem is that Einstein, for example, this picture made him the most famous person in the world, was published in 1945 by Times Magazine. Now you can see there's something wrong with this picture. Einstein never actually came up with this equation, E is equal to MC squared. He never even solved it at the end. He worked on it. Now EMC squared is not related to the atom bomb. And Einstein was never actually involved in the creation of the atom bomb. So you can see our history books have become magazines, and we forget the basics of history. Now, this is Einstein in 1927. That is probably the second last conference. What is not known about Einstein is that basically he was isolated from the scientific community because he refused to accept quantum physics. Now, at this conference, there was a debate between realism and instrumentalism. Einstein said, yes, am I running out of time?
You know, there's Dr. Rampersad would like to say something.
Yes,
Dr. Rampersad?
Conrad, sorry, I was going to ask you this question now. I was going to ask you at the end, but let me ask you it now.
Yes.
The biggest problem that we're having at the moment is that if you have the end result, it's very easy to look backwards and say, you shouldn't have made this decision. But if you're looking forwards and you have a multitude of choices, it's very difficult to decide. And that's the basis of all our medical legal problems.
And Dr. Rampersad, that's exactly my point. Because if you look at instrumentalism, it says that whatever gives you the result is enough. And realism says you must try and look at the nature of the problem. Now, our courts are focused on results, instrumentalism. If it gives me results and I win the case, it works. And that is the problem we are faced with. And basically at this conference where Einstein attended, the instrumentalist won. They said, whatever gives you results is good enough. That the focus of science should not be finding the truth. And that is the problem with our courts. It's not about the truth, it's about results. Now, for example, H.L.A. Hart says, in order to understand the law is about conduct. It's about understanding how judges and lawyers conduct themselves. That is the law. It's not about understanding, he said it's not about understanding legislation or what judges say. It's about, you need to understand how judges conduct themselves. And he said, what is justice? You must understand society. And H.L.A. Hart says jurisprudence answers two questions. What is the law and what is justice? Those are two different things. Apartheid was law. It wasn't justice. Apartheid was law. It wasn't ethics. And H.L.A. Hart says jurisprudence is not only for lawyers and judges. It's actually said it's not the natural habitat of lawyers and judges. And I'll tell you the empirical evidence. The people that write legislation are not judges and lawyers. They are the director generals of the state actually write legislation. Now, that's a problem that we're having. We've left our system on judges when we should basically we are the people. We should actually write the law ourselves and not leave it our interpretation to judges. We should respect authority, but we should question it as well, because it's actually destroying the fundamentals of our democracy. The lawyers are now fighting for the access to the high courts because that's where the money is. It's destroying our profession. All my professors today are not practicing obstetrics in private practice. Because why? Fear. Now, H.L.A. Hart says, how much time do I have at session?
Time to wrap up, Conrad.
Time to wrap up. Basically, I will go to, in our constitution has become extremely complicated. Now, judges basically are forced to interpret the Constitution and use their own values. And I've looked at a textbook. The law has become complicated. There's so many legal theories today. Judges actually don't even agree on the law. They don't even agree on the sources of the law. What are the limits of the law? I will pass it. And basically, if you look at the rules of adjudication, what are judges supposed to do? They're supposed to balance each side. No, the truth is about balancing the facts against the law. And the Hoekstra, this is the important slide. The Hoekstra Commission 1983 reformed the small claim courts. Why? It says legal representation is a psychological barrier. The law of evidence and the procedural rules create complexity. They wanted basically, they removed the laws of evidence, all the complex laws were removed from the same small claims court. Because if you want 20,000 rands, your money is gone on to legal fees. And they changed the system from an inquisitorial, from adversarial to inquisitorial. Their point was the judge must represent the law and both parties. And that was a great reform because it allows you a free, where you go to a court when the judge leads everybody and there's no complex rules that confuse everybody. My conclusion is those who forget history are in the dark ages. Mediation is only a start, but you must start as soon as possible. I started an organization called it's CZN Bentham. What we want to do is to basically give patients a base, psychological support after complication. We shouldn't just dump patients onto the street. When something happens, you should look after them because we became doctors to care about patients, not to make money. Because if we wanted to make money, we won't be in medicine. Thank you very much.
Thank you for that talk, Conrad. We'll move on to the next talk. There is one question pending. We'll try and get to it at the end.
I hope you all got that cryptic sentence in among all those adverts. Please don't forget to use the poll feature to submit your answers to be eligible for these lucky draw prizes. We now move on to the last two speakers. These are short clinical updates. The first speaker, I see he's very keen to go. His slides are come up before I could come on there. Amit Kelpi, who is a urologist at Netcare Parklands Hospital. He's going to take us through now the advances, the 21st century advances in prostate surgery. Over to you, Amit.
Thank you, Anil. I think if I could ask that the backup list of slides could come on, because I'm still having an issue with my slides. There we go, that's better. Thank you, thank you. So it's always good to start with a decent quote, and I think in 1809 Charles Darwin was very much talking about where we are now. It's about adaptation and being responsive to change. And it's very important in all our spheres, including urology. Next slide. So my topic is what's new regarding prostate surgery. And we're going to focus on MIST, which is minimally invasive surgical therapy. Essentially, what we're referring to is procedures that are done in the rooms and are day surgical procedures for the prostate. Next slide. Next slide. So BPH is a very common disease. We know that, next slide. We know that 50% at the age of 50, 90% at the age of 80, with a huge population worldwide. And as we get older and live longer, we're going to see more and more patients come in with these issues. Next slide. We know that there's many causes, and unfortunately, we don't really know the real reason for why it happens. But there's many theories, including genetic, reawakening theory, amongst others. Next slide. Management is broken into different aspects. Next. One would be lifestyle, and that's to try and control your voiding, control your nighttime voiding. Next. And then medication. And medication is by far the commonest first-line treatment, which is your alpha blocker as well as 5-alpha reductase inhibitors. Next slide. And then procedures. And this is the traditional approach. You either, if you have a big gland greater than 80 grams, it's an open prostatectomy. If you have a gland that's smaller, then it will be a TURP. Next. The problem with medication, and this is where this minimally invasive surgical therapy comes in, is that many patients have side effects from medical therapy, including problems with retrograde ejaculation, postural hypotension. 5-alpha reductase inhibitors, by virtue of the fact that they are suppressing dihydrotestosterone, can cause problems with erectile dysfunction, decreased libido in up to 30% of patients. Many patients become depressed on medication. It's been proven that you can develop type 2 diabetes if you've taken it for longer than 2 years, amongst other issues that develop with these new treatments like Duodart, Fincal. Next slide. We know that TURP is not the best treatment either. It's been around for many, many years, and it hasn't evolved significantly from this initial cold punch in 1909 by Hugh Young. Next slide. It has evolved, and then we know that Stern McCarthy led to the scope. This was in the 1920s, 1930s, and the actual technique of doing a TURP has not evolved significantly. Next slide. We know that there's complications, and this is one of the analysis looking at the complications of surgical therapy. Next. With many problems, including bladder neck contracture, with a reoperation rate of up to 5%. Next. We know that there's even a mortality rate associated with surgical therapy with TURP. Next. So the European Association of Urology has evolved the guidelines over the years, and this is our gold standard go-to guideline. And what it has found is that with literature changing and with advances in technology, we have looked at laser nucleation, laser treatment as being the first line treatment for a definitive prostate therapy. Next. Next. And it should be replacing TURP and open prostatectomy. Next. And this is the same with the American Urology Association. They've also found the same and changed their guidelines. Next. 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 And we can just skip through this. And this is essentially just to say that HOLIP is, right. Let's talk about what we hear about, and that's minimally invasive surgical therapy. And what we're referring to are two modalities. The one is hydrothermal, resume, and the second is mechanical, called Urolift. These are office-based procedures. These are procedures where patients come in, have the treatment, and leave without any long hospital stay, done in your office, in your rooms. Next. Unfortunately, this did not project correctly, but essentially, resume is a technique where we insert this device under sedation and local anesthetic, and the size of the actual device is 16 French, so it's about the size of a catheter. And through that, with controlling the applicator, you're able to insert a needle and inject steam into the prostate. So the picture in the middle of the screen shows the needle that would be used to inject into the prostate. The steam therapy is for 9 seconds, and depending on the size of the prostate, you may choose to inject 4 sites up to 6 sites. The idea is that it causes coagulative necrosis over time with an initial swelling of the prostate, and the patient would have to leave your office procedure with a catheter for 4 days. There's progressive reduction in prostate size up to 30% over the next 3 months. Next. So the highlights are that it's an office procedure. It's done with minimal sedation, topical analgesia, 9-second steam injections, catheter in for 4 days, with a proven 30% reduction in prostate size at 3 months. What has been released with an NHS group is that there's a 4% retreatment rate at 4 years, which is by far the best results that have been achieved by any minimally invasive therapy. And currently we're waiting for discovery approval, hopefully by the second quarter of next year. Next. Now, this again, I apologize for the slide. However, this is about Urolift. Now, Urolift has a similar applicator. However, in this case, instead of injecting steam, what we are doing is inserting a almost like a staple into the prostate. It's a device that is meant to pin open the prostate. So there's anchors on either end, as you can see on the picture on the right, that allows the transitional zone of the prostate to be pinched open. And the idea behind it is that, again, it's a day procedure, with the benefit being that there's no catheter required, and that the patient will immediately see a change in the ability to urinate. Next. And this is the applicator that's used. The negatives with Urolift, which are covered by this picture, unfortunately, are that firstly, that the Urolift device is not as tested as Resume, and there is a risk of incrustation and discomfort, as you can imagine, with a foreign object being inserted. Next. As a summary of the EAU, this is the European Urology Association recommendations. We can see that if you're looking at a treatment option that is for a small to medium-sized prostate, that is a day procedure, that is in the room or office procedure, then Resume and Urolift will fit that role. If you're looking at a more robust procedure that would fit any size of prostate, then you would look for something like laser prostatectomy or the old traditional simple prostatectomy. Next. And this also describes where this fits in your treatment, your treatment options, with the most effective treatment with the most side effects being the open procedures, and laser prostatectomy, HOLIP, being with less side effects, being effective in the effective rectangular group on the top right of the screen. The triangle in the middle refers to minimally invasive therapy. They've also included prostate artery embolization, which is currently not in vogue in Europe and in the States due to complications. And we know that the benefits of these minimally invasive therapies are that there's less side effects with a more effective response than medications or behavioral therapy. Next. This is a wonderful summary slide from the Mayo Clinic. And here you can see that medical therapy that was spoken about, that's your 5 alpha reductase inhibitors and alpha blockers, have the benefit of being oral therapy with no procedure involved. However, they have a mild improvement in your flow rate. The prostate symptom score is improved by a mild degree, with the risk of ejaculatory dysfunction being significant at 17%. Next. With the minimally invasive surgical therapy option, the huge benefit is that there's no change in ejaculatory dysfunction, so there's no retrograde ejaculation. So for the younger guy that has problems, that does not want to take medical therapy, this will fit that role. There's no incontinence rate, and there is a further improvement in the flow of urine, with a further improvement in the prostate symptom score. Next. But if you're looking at definitive therapy in a patient typically that has retention, a patient that has a very large prostate, and generally an elderly patient, you would look at a permanent cure. And that's where laser prostatectomy would fit, with an improvement in flow rate up to 14 moles per second, with a massive improvement in prostate symptom score, at the cost being that it's a procedure under anesthetic, currently done as a day procedure though, with mild incontinence rates of 1 to 3%. However, ejaculatory dysfunction is almost guaranteed. Next. I think what you need to remember is that we have to look forward, looking at how we can improve and look at what is available in the first world and try and implant that in our thinking locally. We have the benefits in South Africa of having trusted studies that have been done around the world that we can look at and that we can call upon to guide us moving forward. We should be looking at improving our standard of care. And this is where minimally invasive therapy falls. And I think that's my last slide, Daniel. Thank you.
Thanks, Amit, for an interesting presentation. Can I ask, is this minimally invasive surgical techniques available locally? Is it happening locally?
Well, at the moment, it's not. We were hoping to launch it at the middle of this year. However, with the issues that we've had with COVID, unfortunately, it has limited our ability to bring it across. And we're hoping that it's going to happen, hopefully by the second quarter of next year. There are issues, obviously, with funders being distracted by COVID at the moment, but rightfully so. But we're hoping that would, we would get through to them by the middle of next year.
Good. And just one final question. You mentioned definitive surgery and laser versus traditional radical prostatectomy. Is that, in your view, going to replace radical prostatectomy, the surgery, the laser treatment of removal of the prostate?
And when you say radical prostatectomy, and we're talking about prostate cancer. So this disease is now, we're talking about mainly BPH, and for BPH treatment, we're competing it, or not competing, but we are replacing simple prostatectomy or open prostatectomy. I think it should be replacing simple prostatectomy or open prostatectomy procedures, because we're looking at an option where a patient can be discharged the same day, where the patient at the very least would have the similar result as an open prostatectomy without the discomfort and without the complications associated with that. So I think following what the first world has taught us, that's what we should be doing.
Okay, thank you very much, Dr. Amit Khapi, for the interesting talk. We're getting insights into what happens in all the other disciplines, which is what one of the objectives of this conference is. Thank you very much. We now come to the final presentation of the conference, an update which are on orthopedics. I'll ask Dr. Rinesh Chetty to introduce the next speaker.
Thank you, Dr. Bamdev. Dr. Bamdev asked me very early on or a couple of days ago to please have a read of Dr. Praveen Reddy's CV and just introduce him. I didn't need to read his CV. I had the pleasure of working with him in the spine unit for about 6 months. And, he always showed he was a very practical doctor, very logical and very focused doctor. And I've got no doubt those are the traits that you need to perform foot and ankle surgery. The foot and ankle is often a very underestimated joint because it's the most biomechanically active joint, and it requires a surgeon with logic, focus, and practicality to operate on it. So I've got no doubt Praveen will give us a very, very good talk tonight. And whenever he presented, he never put me off to sleep. So I think he'll do a pretty good job at keeping us awake. Over to you, Praveen.
Okay, good evening, everybody. Thank you, Rinesh, for the introduction and for the opportunity to speak today. For the last talk today, I'm going to be giving you an update on foot pain in the time of COVID-19. So one of the unlikely outcomes of the current pandemic that we are facing is that there's been an increase in reported incidents of foot pain. Some of the theories as to the cause of this is that people are spending more time indoors and at home as a result of quarantine, shifting routines as we try to avoid exposure, and new working environments. As even up to now, a lot of people are still working from home. As a result of this, people are spending more time going barefoot or just wearing socks or unsupportive shoe wear for large portions of the day. And some people are leading more sedentary lifestyles, and as a result, gaining weight. And all of these, which are factors or risk factors for the development of foot pain. So in light of this, I'm going to concentrate my talk today on heel pain, which is by far the commonest foot-related complaint, accounting for about 10 to 15% of doctors' visits worldwide. This is often a frustrating condition for the patient and the doctor. It can often cause severe functional limitation and be quite debilitating. And there are a variety of etiologies. By far, the most common causes of foot pain and heel pain is a plantar fasciitis. So I'm going to be discussing that in detail today. The other common cause is Achilles tendinopathy, and that can be non-insertional, insertional, causing a bursitis, or be bony in origin, which is commonly referred to as the pump bump. Other causes that may arise are the calcaneal stress fractures, usually as a cause of repetitive stress, tarsal tunnel syndrome from compression of the medial neurological structures, a posterior tibial tendon dysfunction, which is usually a precursor to a flat foot deformity, and then subtalar joint arthritis, which can also present as a hindfoot or heel pain. So by far the commonest cause of heel pain is inflammation of the plantar fascia. The plantar fascia is a large band of tissue that runs from the base of the metatarsals to its attachment at the medial tuberosity of the base of the calcaneus. It functions as a shock absorber and helps support the medial arch of the foot. The symptoms of plantar fascia are quite typical and specific, and one can often make the diagnosis just based on the history alone. Patients typically complain of a sharp plantar foot pain during weight bearing. This is usually worse after periods of rest, especially during the first steps in the morning or after prolonged sitting. And it often improves with activity and returns as the day proceeds and with prolonged activity. Despite being a common condition, the etiology is still poorly understood, and it's often multifactorial. The peak age of patients who present with this disorder is between 40 and 60 years of age. Some of the risk factors are patients with a high BMI, patients with reduced ankle dorsiflexion, and this is usually as a result of tight gastrocnemius muscle, which can be demonstrated by a test called a silver skull test. It's more common in patients with cavovarus foot deformity and also in patients who are exposed to a repetitive stress such as runners. So the location of pain is typically at the calcaneal attachment in area 1 on the figure. Also along the substance of the plantar fascia in area 2 and 3, and less so at the base of the metatarsal at area 4. The pain can be exaggerated by palpating the plantar fascia while dorsiflexing the ankle and big toe, as this puts the fascia under maximal stretch. And this also serves as a good diagnostic test to exclude other causes. As mentioned before, a tight gastrocnemius muscle is one of the main instigators of plantar fasciitis. And a gastrocnemius contracture can be elicited by using the silver skull test. A positive test is simply if the ankle can go into more dorsiflexion with the knee flexed than when the knee is extended. And this is because the gastrocnemius muscle attaches above the knee joint. So what about the dreaded heel spur? The most common scenario I'm presented with is patients come in with heel pain and an x-ray from another doctor that shows calcaneal spurs, and they say that they need to have them removed. And because of its appearance on the x-ray, people often associate it with the source of sharp stabbing nature of pain that's associated with plantar fasciitis. Well, its presence is usually an indicator of chronicity of pathology rather than being the actual source of pain. And it has been shown to correlate poorly with patient symptoms, as most people who have heel spurs are actually asymptomatic. Therefore, they are not routinely excised, and they're also difficult to access surgically, and they are close to some important neurovascular structures that can be injured if one has to attempt to excise these spurs. So in terms of treatment, I usually employ a stepwise approach, and I find that counseling is vitally important in getting patients to understand that the natural history of plantar fasciitis is it's self-limiting, and most patients will respond to conservative measures if they are compliant. Most of the therapies can also be self-administered and don't necessarily require referral to a physiotherapist. Therefore, it's important to get them actively involved in their treatment. The two mainstays of treatment are plantar-specific massage and stretching exercises. And added to that, you can use soft heel cups, and oral analgesia and anti-inflammatories also do help. The plantar massage therapy is done with the ankle and big toe in dorsiflexion. And if it's done right, it's quite painful in the beginning, but it does improve the more patients do it. Other methods that are shown in the figures are running the base of the foot along a golf ball or using a frozen water bottle. But the deep manual massage is by far the most effective. In terms of stretching exercises, it usually consists of eccentric stretching of the calf muscle. One can do this against a wall, as shown in the picture, that serves to stretch the plantar fascia as well as the calf muscle. One of the other good exercises to perform is called a heel drop exercise. And as you can see in the figure, you stand with your heel drop below the level of a step, and you stand on your toes alternatively. And this is a very good exercise for stretching out the calf and plantar fascia. So if patients are still poor responsive to this, I move on to other forms. We continue the local physical therapies. You can add custom orthotics such as shoe inserts with a medial arch support. Night splints have been reported to be useful, but unfortunately those are very poorly tolerated by patients, and hence compliance is a problem. The corticosteroid injection is a bit of a controversial topic. It does provide relief, but often it's only a temporary relief, and if it's not combined with the massage and stretching therapies, it's often not effective. It's a very painful injection added to that, and also if it's given on multiple occasions, it can actually cause atrophy of the plantar fat pad, which would be counterproductive in this type of situation. Cast immobilization has also been used, but again, poorly tolerated by patients. Surgery does have a role in new patients who are usually non-responsive to conservative management. And the most common type of surgery that we perform is a plantar fascia release and a release of the inferior calcaneal nerve, which is often called the Baxter's nerve, which compression of that nerve can also mimic a plantar fasciitis type pain. And added to that, based on clinical exam, we may also do a gastrocnemius elongation at the same time. When you're looking at Achilles tendinopathy, as I mentioned previously, you can get a non-insertional type, which occurs within the substance of the tendon. This is usually age-related, so patients, again, above 45 to 60, that's where you see this type of problem. And patients present with a swelling along the tendon. They can have pain, crepitus to touch, and you can often sometimes feel a warm, palpable mass. It's interesting to note that only 30% of patients who have Achilles tendinopathy will go on to a complete or partial or complete tear of the tendon. So it's not necessarily a predisposing factor. Ultrasound is usually the investigation of choice to look for cysts or micro tears in the tendon. Again, conservative management is the mainstay of treatment. With the non-insertional type, you really have to modify a patient's activities. They basically have to rest the ankle. Ice does work, compression, elevation, non-steroidal inflammatory and anti-inflammatories, as well as calf stretching once the initial pain does settle down. There is a treatment that's called brisment, which involves injection of a large amount of dilute local anesthetic into the tendon sheath. Also not 100% in its effectivity. But here, corticosteroid injection is not recommended because you can actually compromise the tendon integrity. Again, night splints have been shown to be useful in certain people. Surgery is indicated in cases that are really resistant to conservative measures, and those are usually reserved for patients who show micro tears or cyst in the tendon, and the surgery involves debridement of the tendon or the paratenon and repair of any tears if present. When it comes to insertional Achilles tendinopathy, there's two types really: is the soft tissue insertional tendinopathy and the bony, which is the Hagelin's deformity. In terms of the soft tissue, it's often associated with inflammatory processes such as arthropathy, gout, more common in patients with diabetes and obesity. It may be associated, as I mentioned, with the soft tissue inflammation of the retrocalcaneal bursitis, or a bony deformity, which is the Hagelin's deformity. Again, we utilize conservative measures in the initial phase: activity modification, simple analgesia, short periods of immobilization do work, such as using a moon boot, and then eccentric calf stretching once the pain settles down. Here you can use a local anesthetic and corticosteroid injection. So long as you don't inject it into the tendon itself, you can inject it around the base of the tendon into the retrocalcaneal bursa, and it has been shown to be effective. Again, surgery for cases that are poorly responsive, and that usually involves debridement of the base of the tendon and the bursa, and if the tendon is torn, reattachment if necessary. When talking about the Hagelin's deformity, this is a bit of a different problem. It's more a chronic problem, and this is where you get bony deposition at the base of the Achilles tendon, often referred to as the pump bump, and the patients present with an enlarged and prominent posterior superior aspect of the calcaneal tuberosity. This is, as I said, a more chronic form of insertional tendinopathy. Conservative treatment can be employed, such as modification of shoe wear, use of non-steroidals, but this is unfortunately less successful because this is a more of a bony pathology rather than a soft tissue. And the treatment here is usually, if it's not responsive, we excise the bony exostosis where the Achilles attaches, and we reattach the Achilles tendon to the new base. Because we have to reattach the tendon, there is a period of rehabilitation required. That's usually 6 to 8 weeks of a tailored physiotherapy program. So as mentioned previously, some of the other causes of foot and heel pain can be a tarsal tunnel syndrome, Also can present with medial-sided pain, calcaneal stress fractures, usually in high stress situations. And the investigation of choice here would be a CT scan to rule out a stress fracture. Posterior tibial tendon dysfunction is often a precursor of the flat foot deformity, and they can present initially with pain along the medial aspect of the ankle. And another culprit is subtalar joint arthritis that presents with hindfoot pain. So in summary, a heel pain is quite a common pathology. It seems more so now during this COVID pandemic. The cause can usually be elicited through clinical examination. I find that patient information is vitally important because most of these can be treated conservatively with good compliance from the patients. And surgery is really reserved for cases that don't respond over a long period of time. Okay, thank you very much for your attention.
Thank you, Praveen, on that talk. As I said, heel pain is an extremely important subject, foot pain as well. Are there any questions, Dr. Bamdev? Or are we saying goodbye to everyone? Okay, so I'd like to close the last day of the, or close this day of the conference. As I said, Praveen won't let you fall off to sleep just yet. Thank you, Dr. Bamdev, and to the rest of the delegates.
Thank you, Rinesh. I think that brings the whole conference to a close now. Let me say a big thank you to many people, okay? First of all, I'd like to say a big thank you to Discovery Health, especially to Renard and Anika. They provided us the webinar platform and provided us with all the technical support to make this a smooth flowing conference. So Anika and Renard, thanks once again. I want to say a big thank you to all our speakers and all the panelists over the 3 sessions. A big thank you to all the sponsors, and also a big thank you to my fellow KZN Specialist Network EXCO members, especially those of the conference subcommittee. But lastly, the biggest thanks must go to our secretary, Tanya, who's done all the background work and who's made this whole conference successful. Tanya, thanks a lot. Just a reminder that all the presentations will be available. It was recorded, so it'll be available on our website, probably from about Monday or so onwards. All 3 days will be there, so you're welcome as a member to log in and you can view all the presentations there on the website. A final reminder to enter our competition. You have a few minutes left. Okay, please use the poll feature and you can make your last minute answering to the questions. I promise we're going to do a very fair draw. It'll be done under auditor supervision. We will not entertain any Trump-like objections. Okay. All the winners will be notified by email and the gifts will be personally delivered to you. So with that, I would like to say good night to everybody. Please be safe as we go into the holiday season. Our KZN Specialist Network academic year has come to an end. We will resume early next year, probably in the 3rd or 4th week of January when our next meeting will take place. So thanks once again to everybody and good night.
Bye.